Hello and good afternoon. On behalf of EcoSense, I would like to thank you all for joining us for this webinar today. I am Neha Parekh, the Clinical Application Specialist for EcoSense and the moderator for this session of the webinar entitled FibroScan Examination Procedure, Review of Best Practices. I would like to take the opportunity to introduce to our experts today. We have here Dr. Patrick Kennedy, who is the Consultant Gastroenterologist and Hepatologist at the Barts Liver Centre, London. We have Lewis Campbell, who is the Specialist Senior Nurse at Imperial College Healthcare, London. And we have Mr. Mark Lundu, who is the Clinical Training Manager at EcoSense. Before we start, I would like to remind you all that we have an online chat video window open for you to send us any questions that you may have during the webinar. In the end, we will have a Q&A session where we will be able to answer all your questions. Thank you again for joining us today. So to start with, we will be covering a lot of different topics today. And we start with the introduction, talking about the FibroScan examination recommendations, some tips and tricks to scan difficult patients, review of some clinical cases, and then finally the Q&A session. I would now like to hand over the floor to Dr. Kennedy to go us through the introduction.
Thank you, Neha. Good afternoon, everybody, and welcome to this EcoSense webinar. I'm sure you're all very familiar with FibroScan, but I just want to highlight some of the key aspects of FibroScan today. So as you know, FibroScan is a simple test. It is essentially a test that we're able to perform a non-invasive quantification of two physical biomarkers, essentially within a 10-minute period of time. So how does FibroScan work? Well, essentially it involves the generation of a shear wave. This is made by the vibrator, which is passed into the liver. And then we use an ultrasound transducer to measure the return of that wave. Essentially, the measure of the velocity of that wave is a measure of the liver stiffness or scarring of the liver. There are two key things to remember with FibroScan. That FibroScan not only just measures the liver stiffness, we document here as the LSM or liver stiffness measurement, but it also measures the CAP score, which is the controlled attenuation parameter, which is essentially a measure of fat in the liver. The thing about FibroScan, where it actually has a lot of benefit to us, is that it's able to really comment in about a 3 centimeter cubed area of the liver, which is a significant interpretation of the liver when we undertake this examination. So what's involved? What are the techniques used? Well, as I mentioned, it's the generation of a shear wave, which is passed into the liver. Then we have this ultrasound transducer, which measures the shear wave, the speed of the shear wave. And then the FibroScan machine computes this into a corresponding liver stiffness or scarring of the liver interpretation. And essentially, there are two ways of looking at this, that the more scarred the liver is, the higher the stiffness and the higher the speed of that shear wave. If the liver is essentially normal or normal within normal considerations, then the speed is low, and that equates to a low stiffness score or liver stiffness measurement. Here's a simple elastogram that we're showing you. This is one of the readouts that you will see when you undertake FibroScan. And essentially, we're just going over similar aspects of this that you're aware of. The velocity of the shear wave, which again equates to that stiffness. And if we look at it in a little bit more detail, the elastogram is showing as a function of the depth and the time. And then the FibroScan machine converts the shear wave velocity into kilopascals, and the result of the measurement of liver stiffness is, of course, given in kilopascals. But we also talked about the CAP score. The CAP score is very important and is something we recognize more and more has great utility in terms of using FibroScan in the clinic today. And the CAP score we're using to measure fat within the liver. So what does the CAP score do? Well, it is measured by sending ultrasound waves within the liver and measuring their attenuation. And then we also know that the CAP score is able to correlate with a decrease in amplitude of the ultrasound waves as they propagate throughout the liver, as shown here. So again, we're able to get, in a fatty liver, we get a high ultrasound attenuation rate. You can see, given the value here at 313, which is quite high, that's an elevated CAP score. And then in a normal liver, we see a low ultrasound attenuation rate, equating to a low score, as shown here, in the 134 decibels per meter. And finally, when you are undertaking a FibroScan, there are three probes that you can use, the S probe, the M probe, and the XL probe, and you will make a decision about your use of the probe based on the patient that you're seeing. More commonly, obviously, we'll use the small probe in the pediatric setting, but the M probe being the most common probe that we will use, and the XL probe being reserved for patients with higher BMIs, etc. But the decision making here around the use of the probe is based around patient age, thoracic perimeter, and also the skin to capsule distance in the patient, often a reflection of subcutaneous fat and a good measure of which probe is likely to be successful. Essentially, the measurement is depth and ultrasound frequencies. These are adapted for each of the probes. So you'll see here the different frequencies given for the small M and XL probes. And generally, the selection and use of probes, we get very good success rate in terms of the readings that we're able to get from FibroScan. It's probably worth saying that as patients have increasing BMI, there may be some reduced success rate, and we're just showing you here that BMIs of greater than 50, the success rate can drop to about 70%, but even for patients with BMIs of less than or up to 40, the success rate can be up to 95%.
Thank you, Patrick, for telling us the introduction about the FibroScan system, the technique and the principle used to measure the liver stiffness and the cap. I would now like to go to the next topic, which is the recommendations by the FibroScan, and I would like Mark to go through us about the different recommendations that we need to follow to get reliable readings.
Thank you, Neha. Welcome, everybody. So I would like just to stress a little bit the recommendations provided by EcoSense for the FibroScan exam. So what is actually recommended, as probably you already know, is that it's important for the patient to be fasting for at least 3 hours before the exam, because we all know that the digestion might affect a little bit the blood flow and ultimately the liver stiffness value. Another recommendation that you might not all be aware of is that it's important that the patient lies down for at least 3 minutes on the bed before you start the exam, because we have realized lately that the hemodynamics might change a little bit between the standing and the lying position. So this time is actually required to ensure a good results and reliable results. Regarding contraindications, it's also important to remember that now we have EcoSense removed all our contraindications related to the use of FibroScan, so it's perfectly safe now to use the FibroScan on pregnant women. There have been data published on this, of course, on this type of patient. The same for patients with pacemakers or any implantable active medical devices. There is no contraindication about that. There is maybe an exception for the United States, for which FDA still needs to approve this, the use of the FibroScan in this setting. Otherwise, I would like to highlight, and I think we are going to discuss that later in the webinar, that there is no risk to scan patients with ascites. Very often the exam might be challenging. We are going to provide tips and tricks, but there is absolutely no risk for the patient, at least to try. Regarding now the exam workflow, so the FibroScan exam is mostly four steps to be followed, and I would like to highlight the fact that probably the first one is the most important one, what we call the localization phase, because this is exactly the time in which you will take the time to find a good spot to look at the ultrasound image on your FibroScan to ensure that the probe is well positioned. And it will actually be very important to ensure later on a good result and consistent values on the FibroScan. Of course, once the position has been found, it's time to do the exam. Everybody knows that you need to do at least 10 measurements, valid measurements at the same spot within the right lobe of the liver. What is also important is to check the quality of the measurement. Every operator needs to be aware of what is a good and what is a not good signal to ensure a good and reliable value for both liver stiffness and cap. And at the end, of course, it will be the time to send and end the exam. To get back to the examination procedure, so this is something that probably not a lot of people already know, but the way that we position ourselves with the patient is really important, and I would like also if Louise and Patrick want to comment on that, it might be very, very, very nice as well. So it's very important to sit comfortable when you are doing a FibroScan. In the vast majority of cases, the exam will be easy and fast, but there are some patients more difficult, and if you are not well seated, not well positioned, then it will be more difficult to get a good readings. So it's important to be sitting at the same height compared to the examination bed, ideally on the height adjustable stool or chair, to be parallel to the bed, to be able to check both the screen, where you will have a lot of signals to check, and also the position in front of the lever. Regarding the patient, the banana position, as we commonly use this term, is also important. It helps to ensure that the ribs of the patient will be wide enough to put the probe in between. Crossing the legs might be also helpful for some patients, again, to widen the intercostal space and to avoid to hit the ribs with the tip of the probe. Finally, to find the lever, there are different methods. One of them is using anatomical landmarks, using the xiphoid process and the mid-axillary line intersection. This is where you would approximately put your probes, and then there is a need to adjust the position based on the signals you get on the FibroScan machine. So this is for approximately how to set up the examination room and how to position patient and operator. Now, if you want to go for a probe, it's pretty important, as Patrick said already, that you have 3 probes. There are actually criteria for each single probe, which are based on either thoracic perimeter of the patient for S probe, or not BMI. I insist on that. BMI is not a good criteria to select between M and XL probe. You have to look for the skin to liver capsule distance, which is actually automatically measured by the FibroScan system during the exam. So it's pretty important to follow the probe recommendation, which is actually displayed on the screen. It might tell you if you need to use M probe or XL probe, depending on this skin to capsule distance measured by the system. If now you want to check for your quality of signal before hitting the button, I would like to insist that what EchoSense recommends is really to take care of the signal, the ultrasound signal that you get on the screen. As you can see on the image here, it's really important to get a nice uniform layers, which is a typical signal of the liver within the measurement area, the region of interest. And you have this indicator that we call in the LTT for liver targeting tool that will give you an indication on how good is your ultrasound signal at the current measurement point. So it's really important that this bar or frame, depending on your software version, is intense green. Intense green means that your positioning is good, and if you have the layers plus this green bar, you will ensure a good position. It will save you time for the examination. Last thing, as some of you might already know, is the importance of keeping the probe perpendicular. When we say perpendicular, it's perpendicular to the patient's skin. So it's really important to keep this probe perpendicular to the skin, otherwise there is a risk that the stiffness value is slightly overestimated. So it's really important to keep the probe perpendicular for your 10 measurements and not for the 2 or 3 first measurements, otherwise there is a risk for you to see your values increasing a little bit. Finally, regarding quality check, as we have seen earlier, it's really important to look at the elastogram quality. So there is sometimes a risk to hit the rib with the tip of the probe, and you would end up with rib echoes, as you can see on the screen. That leads also to higher false positive values. They should be avoided by changing of intercostal space, moving to another intercostal space. So this, of course, is something to take care of after each individual measurement. Another incorrect signal you can get is if, and we'll talk about it later, if you try to scan overweight patient, if you don't have Excel probe in your center, or if you are scanning a morbid obese patient, there is a risk to get, as you can see on the slide, fat subcutaneous tissues visible, this white pattern on the ultrasound signal, and that might disrupt travel of the shear wave. This might cause this type of what we call angled wave on the elastogram. This is not recommended. Of course, if you see that, you should switch to Excel probe and you should try to stretch the skin of the patient. We'll get back to this later when we'll speak about difficult cases, to try to avoid this type of signal and to get a good result. Finally, important once you have completed your examinations to take a look at the median values of both the CAP score and the liver stiffness score. What we do recommend, EcoSense, is to keep the IQR median percentage for liver stiffness maximum 30% to ensure a good result. There have been data published on that, Boursier criteria, and which are now adopted, I would say, by most of the users. I would like to highlight that for now, and we'll discuss again this a little bit later, there is not yet official criteria for reliability of CAP. So for now, this is why you do not see the IQR over median percentage displayed for CAP score. So that's where the official recommendation. I know we'll now pass the floor to Louise and Patrick to comment a little bit about the liver stiffness influencing factors.
Yeah, I think, Mark, this is a very important point, that we know that if a patient has a FibroScan and they've got active inflammation with elevated ALT and AST, that this can quite often give a falsely high reading. So this is why we want to undertake the FibroScan when we think maybe a patient is beyond a period of inflammation, for example, like we show here with alcoholic hepatitis or whatever. But there are other reasons too to consider, such as, the operator may be inexperienced, has the patient fasted appropriately? I think Louise is going to add something to that also. And then, you have to think about, again, the individual patient that you're scanning. You have to think about obesity would be one of the key things and what probe you may select and use. And, of course, liver congestion in the context of right-sided heart failure. But, Louise, you wanted to add something on the fasting.
I think it's difficult when you're looking at influencing factors. A lot of FibroScans today are done by technicians. Or even when we get referrals for FibroScan, I do not get, or my team get that amount of information. So when we give you a stiffness result that comes back, it is the physician's responsibility to check all of the traces for validity. It is also the responsibility to know the confounding factors that may influence those scores. And we see more and more referrals now from non-liver areas, methotrexate monitoring for guidelines, cardiovascular disease. And we're talking with physicians and looking at scan results who may not know how to interpret them as well as gastroenterologists or hepatologists particularly. So these are really important. I think also knowing whether your patient smokes, because your liver will be in a different position potentially for somebody who's a regular smoker because their lung capacity is extremely increased. So if you can't find it high, it's worth asking your patient whether or not they've certainly been a smoker over time.
Thank you, Mark, Patrick and Louis, for sharing us with the recommendations that we need to be follow during the FibroScan procedure. And the most important is the quality criteria to actually get some reliable readings in the end, which should not be more than 30%. Now, we all know that FibroScan can be a very easy procedure and it might not take more than 5 to 10 minutes per patient. But sometimes when you have such difficult patients, you might be spending more than 20-30 minutes to be scanning those patients. So now the next topic is to discuss the tips and tricks. And I would like Louis to highlight some of the tips that she can help us to scan some difficult patients in our daily practices.
Wonderful, thank you. Looking at tips and tricks for difficult to scan patients, actually every patient can be difficult to scan. You can get the absolutely perfect patient that you show on all of the EcoSense videos with no fat, perfect ribs, lovely wide spaces, and actually sometimes you just can't find. So I think if we look at overweight patients, yes, there's an unreliability in the stiffness in the cap if you don't look at the depth that you're going and pick the right probe for those patients for that. So you're looking at the adipose wall, but I think it's really difficult. Male patients carry their weight in a totally different position to female patients. So just saying that somebody's got BMI, and I think Patrick alluded to that earlier, is difficult. To say that I'm going to need an XL probe on a gentleman who's got higher BMI is actually not necessarily the case, because their fat is all frontal and their rib cage is often very easy to get to, and any of the users out there will be able to attest to that. Women, on the other hand, however, don't. They carry a lot of their weight around their ribs. So even patients who aren't necessarily high BMIs or aversely overweight can just have a different adipose disposition, and I think that's important to take care of. So it's about assessing that patient when you see them on the screen, on the table or the bed. So you can get a lot of measurement failures, which is why the statistics show that FibroScan with the XL probe drops to around about 70%. So those are one of the reasons. Exaggerate the bending in the patient. I think and for some patients, crossing their legs because of their back problems may not be the best one. So actually just taking the left leg out and joining the right leg to the left leg actually helps anybody who's got more spinal difficulties and more pain. Obviously, again, you have to take consideration of the pain and any discomfort for the patients, so you need to keep them in a position that they're comfortable in so that you don't do any damage. But by doing that, you just open the rib spaces, and that's often exactly what we need. But also moving the probes round the body, which we show here. So we're stretching out the skin. And one of the techniques that I tend to use quite a lot is I try in these patients with high fat and adipose tissue round the rib cage is to actually use a one-handed technique. I know that's not necessarily what you advise, because I can push the skin and allow the probe to get closer to the patient's rib cage. So I will clear the skin with my right arm, but also you've got to be aware of your shoulder and position in that. But I can actually get the skin to capsular depth a lot closer with a one-handed technique, but it's about the stability of the left hand on that. So by stretching out and putting down, it does allow me to move those probes around. And I think this is a nice slide, because quite a lot of the videos online and when it's initially taught to us, you pick one position. And people genuinely don't believe they can move. And I think your liver is quite a large organ. So actually, and some of these patients are extremely large, so their liver is larger. So they will take moving the probe up and around and down. So try to get the best traces. And using the liver, using the anatomy, using the rib cage to allow you to pick the liver is quite nice in some of these larger patients. So, as I say, stretching the skin about the ribs, also using two fingers or your finger right round. That also allows me to get quite close and keep the probe perpendicular, because as they breathe, that moves as well. So the one thing I'd say on tips and tricks, whilst the patient is extremely important for finding the right spot, the actual user and the person scanning is just as important, if not more important. Because a lot of people I watch and teach will change their whole body position to find the next spot for the probe. You can't see the liver through the skin. So actually, I tend to ask them to fix their shoulders at the screen, and once they've got a spot, move. And it's fractions of millimetres for some of these scans to get the right trace and the wrong trace, which we'll all be familiar with. When that patient breathes in and out, you lose the trace, you can find it back again. And I think picking the same depth on inspiration or expiration where you've got great traces is also a good tip, because you know you're getting quite a consistent reading, and you often see it in the traces. So patients with narrow intercostal spaces. A small probe can be used, but you obviously can't get the cap, as we all know, on the small probe, which is ideally designed for small adults and paediatrics. We tend to use it a lot in. We have a big Southeast Asian population who have very small rib cages, A lot of our Indian ladies, again, have small rib spaces. So after exaggerating the patient, if you really can't, I try with the small, but actually probably 99% of the time I can get a medium probe onto some of these patients, but it can take longer to find those locations. And again, moving the rib cage around to do that. So muscular patients, these aren't just your gentlemen or ladies who go to the gym and do weights. These are your patients who use wheelchairs, who use higher upper body strength to mobilise round. And some of those can be really difficult because they're extremely muscular around there. So again, using the enhanced placement around the rib cage and lower may well help you. I think if you have a mobile bed, one of the techniques I like to try is, if I really can't get it, is to raise the bed so I come from behind slightly. The liver, we know, gravity tells us it's going to be towards the back, and sometimes I can get a better trace through the back, clear on the liver, underneath the muscular tissue there. So again, it's trying different spaces and persisting. So not all patients, this chap on the screen there, normal BMI, normal, he's got a lovely rib cage, but not going to be necessarily the easiest. So looking at a patient thinking that's going to be a quick scan, it doesn't necessarily go with the patient. So taking time and having plenty of time for that and not getting frustrated. I think we all see the green, green and green on these traces, and sometimes we just can't get a scan. And sometimes you don't get green, green and green, but get perfect traces and you get a perfect scan. So as it says, it's there to assist us, but it's not carte blanche. So children, small probe, and as we know, the small probe on the screens, you just press the button for S1 and S2. There's no two probes for S1 and S2, which some people ask me every now and again. So ideally, for patients with less than 45 centimetres for S1 and above 45 centimetres and below 75 for S2. But that's also a category of patient that does really well on the medium probe once you find a really good trace. Because as we know, as I've said, the CAP score and therefore FAT score is not available if we use the S probe currently. And we are seeing more and more children of a younger age coming with high fat, high BMIs. So recommendations for children. I'm lucky I've got two paediatric nurses who spend more of the time with the children, but using all of the probes at your disposal is really key. We do have the XL, and we're now using the XL more and more on the older children. But very young children, as I've said, the S1, you can get good readings. You then might want, or the S2, you then might want to do the medium probe to get a really nice trace, to get a really good CAP score, and it helps because children see diets now is slightly different. Calming the child, I think a lot of people use the same techniques. Children can take twice as long as an adult to get into the position, to just cajole into lying on the bed. A lot of children find this tickles, so actually laughing during a FibroScan isn't uncommon, but it's a really difficult thing to scan through. Because more children are now obese, I do find the adipose tissue in adolescents is so much softer than adults, and that causes its own problem because the probe moves an awful lot more. So it's really difficult. So getting that centralisation and fixing of the probe in the right place can be even more difficult, and I think our paediatric nurses would attest to that as well. So they can be more challenging for lots of ways, but with fatty liver disease growing, it's absolutely vital we get these scans off these children now. So the conclusions to take home from this, that with either FibroScan with either the medium or XL is highly applicable in the vast majority of cases. So using them together increases the amount of options that we have and the amount of people we can scan up to over 97%, including NAFLD. Pre-examination requirements include fasting and lying in the position for 3 minutes. I'd also put in there that chewing gum is not fasting because of the anatomical changes that chewing gum does, when a lot of people like to keep their mouth moist and chew gum. Localization phase is crucial for the rapid and consistent examination, but I'd stress it's more about the consistent examination than about the speed. get the right examination of the person, not about the speed particularly. And quality check all the way through, because we're trying to obviously get 10 readings, 10 in a row if we can, but I will never take the first 10 because the breathing is settled, even if they've been lying for 3 minutes. It's about looking, you will see it start to come down as they relax a little bit more. Particularly those patients who've never undergone a FibroScan before. They are slightly anxious. They don't know whether it's going to hurt, even though you reassure them it doesn't hurt. So getting that reliability of those traces as you go through is absolutely key. Thank you.
So thank you, Louis. I think that was really helpful for you to discuss the tips that we can use for daily scanning patients. And I think the key point for me I would like to note here is that we need to take enough time to spend and get the right spot within the area. We should not be stuck to just one point between the rib spaces, and we should move around to get a very suitable area where we have wide spaces in between the ribs to get some good, consistent readings. So moving on to the next topic now, we have some 4 or 5 clinical cases that we would like to discuss, and these have come from Patrick and Louis. And maybe turn by turn, we can just go through all the cases.
Thanks, Nia. So this is the first case that I've presented. So this is a 56-year-old male. I mean, we talked about the importance of knowing your patients and knowing their background so you can interpret the FibroScan in the context of their conditions and possibly even their comorbidity. So this is a patient with a BMI of 28.5, a recent diagnosis of type 2 diabetes, a background history of essential hypertension, which has been managed, hypercholesterolemia. So we're already beginning to get a picture of a metabolic syndrome. We're thinking, has this patient got fatty liver disease and consequences related to that? But of course, there's also a history of alcohol. So even though the patient is teetotal for the last 3 months, there are a number of factors here which could be contributing to potentially a high reading on the FibroScan. So let's see what the FibroScan showed. So here we have the FibroScan is performed with the XL probe. And straight away you can see that the median liver stiffness is 15.9. The CAP score is 328. So the first thing you're going to think is this is an elevated FibroScan with a very high CAP score consistent with a significant degree of hepatic steatosis. But actually the most important aspect of FibroScans and using FibroScans is really the quality metrics. So let's draw our attention to the quality metrics here. So there are a total of 10 valid measurements from 69 measurements. So that suggests to me that there's been a lot of measurements taken in order to get to the required 10 readings. But I think the standout here is the IQR median for the liver stiffness at 94%. And as Mark alluded to earlier, this really is too high. We would not consider this to be a technically good study, and therefore the interpretation of the scan is certainly questionable. You will also see that we've highlighted here the ultrasound reading showing you probably a significant area of subcutaneous fat, again, which is going to affect the result and the interpretation of the result. So we've got some conclusions that we can draw from this case. And this is essentially going back, looking at the quality check. What is the quality here? So yes, we have 10 valid readings. We're happy with that. The IQR median, clearly not adequate in this case, not less than 30%, so that's not satisfactory. We know that we have a homogeneous ultrasound signal with the green LTT that Mark referred to earlier on, which is good. But finally, the elastograms don't meet the quality criteria that we would like to see again. So essentially, this is a FibroScan in a patient with multiple comorbidities where we're not entirely happy with the quality metrics. And essentially the conclusions I would draw from this scan are that, well, first of all, patient with a high BMI and high skin to capsule distance, as we showed you in the earlier scan, is probably diminishing our ability to use this as a good quality FibroScan. The skin to capsule distance at about 5 to 6 centimeters is really quite high in this case, again reducing the FibroScan accuracy probably. And the presence of this subcutaneous fat, as we talked about, really is an issue which is going to disrupt propagation of shear waves and again your interpretation of the result. The stiffness and CAP scores are likely not to be reliable, as I said from the outset. And this is probably an example of a patient whereby FibroScan may not be the ideal setting for the evaluation of this patient's liver disease. We've seen lots of factors here which are against a good quality FibroScan. So maybe this is a FibroScan which demonstrates some of the limitations of FibroScan in a patient of this type. So, we would consider other options for assessing this patient's liver disease.
Clinical case 2, 18-year-old male, 120 kilos. A growing population that we're seeing, no history of alcohol excess at this age, admits to a poor diet, high fat intake. ALT was 276, AST 120, triglycerides 3.18 and cholesterol 3.18. Rugby player, doesn't want to lose weight for fear of losing his place in his rugby team, so he's got peer pressure. 1 year history in an 18-year-old of nausea, abdominal discomfort, and now takes intermittent omeprazole. So let's have a look at his scan. So FibroScan was 9.5, CAP score of 236. But we can see by the scan you've got an IQR percentage there of 475, so it's not a valid scan. It wouldn't be put on the patient's records for fear of somebody misreading that scan, but we've got valid readings, which are excellent. And there's the odd valid reading in there, but go to the next slide. So if we're going to check that quality, we've got 10 valid measurements. We've got a good space of the measurements. We didn't need too many to get them. But we do have an IQR that's above a valid range, so it's greater than 30%. We did have good ultrasound signals. It was green, green and green. And the elastograms didn't, however, meet the quality criteria for that. So the CAP examination in here does look to be relatively reliable for this patient. The presence of the rib echoes causing the dispersion of the waves through there means that the IQR was greater than 450% and certainly well above the greater than 30% that we would want, less than 30% that we'd want. So the stiffness examination isn't valid, it's not reliable, and it would need to be performed again. And that's about quality checking your controls and being aware of your shear wave traces as you're doing the test, because then picking up, moving the probe to a better region to get a better trace earlier rather than I'd recommend in that.
So this is another case of mine. I mean, this is a typical patient from my clinic. So it's a 38-year-old patient, 38-year-old male patient with chronic hepatitis B who has got e-antigen negative disease with a HBV DNA which is undetectable on antiviral therapy. So this is a patient who would have been risk stratified at the outset before starting treatment. And to begin with, the patient had a high FibroScan reading. So we're very keen to follow these patients very closely, to FibroScan them longitudinally, especially when we've reached a state where we've got undetectable viremia and normal liver function. So it's really important for us to follow these patients, and FibroScans are an ideal tool to do this. Interestingly, the patient also had a history of alcohol, but had reduced their alcohol on our advice. The liver ultrasound was satisfactory, and as I said earlier, the biochemistry was good, normal platelet count. So this is a good patient following all the medical advice given to them, taking their drugs and reducing their alcohol. So the FibroScan, you will see, when you look at it at the outset, it is an excellent FibroScan. This is an ideal patient following all the advice with a FibroScan, median liver stiffness of 6.8, IQR median of 18%, low CAP score reflecting normal levels of liver fat. And if you look at the valid readings, 11 out of 12, IQR median 18%, excellent FibroScan. One slight issue though, and that is that if you look at the ultrasound, you can see the presence of vessels. And the presence of vessels there is something that, when you're performing FibroScan, just underlines the necessity to look at actually what you're doing. It's not just about the readings of the FibroScan, the readings of the CAP score, because this may have implications in your interpretation of the scan. So let's see what those implications are. So let's look at the quality metrics. We've had 10 valid readings. We're happy with that. IQR median, which is very good. But we do not have a homogeneous ultrasound signal with the green LTT demonstrated, but the elastograms were of good quality, so they met the quality metrics on that element. So what conclusions can we draw? Well, the examination is reliable for liver stiffness, so we're happy with the median liver stiffness. We're able to suggest that this patient has done well. The level of fibrosis is certainly improving, and there's no issues with that. But however, Given that ultrasound reading and the homogeneous signal that we talked about above, the CAP result we'd probably say is unreliable in this patient, owing to that poor quality of the ultrasound signal. So an important case to demonstrate where liver stiffness could be interpreted with good metrics, where the CAP score may be less reliable. So this is another case of mine. This is an important case because it highlights the question around the presence of ascites in chronic liver disease, decompensated chronic liver disease. Can we use FibroScan? How accurate it is, etc. So this is a patient with a history of alcohol-related chronic liver disease, a patient who presented with decompensation but has been teetotal for 4 months. Interestingly, at the initial presentation, had large volume ascites, treated with diuretics, very good response to diuretic therapy, and now under follow-up in the clinic with only mild to moderate levels of ascites. So we're pretty happy that the patient has done well, has made good improvements. The liver function, the liver function is preserved, and at endoscopy there's no esophageal varices. So we're beginning to develop a picture here of what the clinical profile of this patient is. So we undertake a FibroScan, and you will see here that we have 11 valid measurements out of 13. The median liver stiffness score is 17.3 with an IQR median of 20%, highlighting that this is a technically good study with good quality metrics, but obviously a significantly elevated liver stiffness score. The CAP score is 206, but the issue in this case is what about this interpretation of fluid, and what does the presence of ascites do in terms of our interpretation of the overall score? So let's go forward and see, first of all, looking at the exam quality. So back to the metrics, 10 valid readings, we're satisfied with that. IQR median less than 30%, very good. Homogeneous ultrasound signals with the green LTT throughout. Elastograms meeting the quality that we'd expect them to see. So despite the presence of fluid, the shear waves could propagate correctly. Despite the presence of ascites, we're able to undertake a FibroScan, and we're able to say that the examination is reliable for both median liver stiffness and the CAP score, highlighting that when we're able to treat these patients, control them, get them into, let's say, a period of recompensation, FibroScan is able to be used as a measure to really quantify the amount of liver scarring and even the CAP score.
And I think one of the tips for doing patients with ascites is being able to see an ultrasound that's relatively recent for the amount and the volume of ascites. Obviously gravity, when you lie that patient down or even slightly elevate the head of the bed, will push the fluid down. So you're looking for a higher position on the patient's chest to make sure that you're as far away from the fluid as you can possibly be. So they are scannable. It just takes a little bit of time to get these patients, and they're very valuable because, I don't know about you, I find that 17 is not a bad score for somebody with cirrhosis, but normally decompensation would be a lot higher. So I wonder whether the presence of the fluid actually makes it look slightly softer than it probably is.
I think they're very valid points, Louise, definitely. I think one of the key take-homes for me is that if you have a patient presenting to you for the first time with decompensation, the first thing you don't do is let's do a FibroScan. What you want to do is you want to assess the patient in a kind of more global sense. You want to offer those interventions, and at that stage, when maybe there's been some improvement from the initial presentation in terms of volume ascites, response to treatment, and even the liver enzymes maybe settling down after a period of absence or whatever, will give you a more accurate test. So there are a number of factors which are really important to consider when you're undertaking a FibroScan in a patient like that. But going back to what you're saying earlier, Louise, to me, the most striking element here is that the individual who's undertaking the FibroScan knows that patient in front of them, knows their presentation, knows the laboratory test, knows the ultrasound scan, and then they can put that much more into a broader clinical picture than just simple readings or trying to interpret something which may be inaccurate.
Right. Thank you, Lewis and Patrick. That was quite a variety of cases that we saw today, and as you said, that we have to also take the history of the patient into account, and not just the FibroScan score is quite vital. So now coming to the last part of the webinar here, we have an interactive Q&A session, and I think we have received quite a few questions from our audiences today, so we would try and answer them one by one. So going to our first question here we have is, can I use the XL probe on all my patients? So I would like, maybe Mark could answer this question.
Yeah, maybe I will start by maybe giving you the official recommendation from EcoSense. It's a highly controversial questions regarding comparison between values, between M, XL probe. When shall I use the XL? When shall I use the M? Shall we compare the results done on the same patient? Well, our position, EcoSense, is we have designed probes dedicated to different morphotypes of patients. So as you can see on the slide, the probe have different measurement depths between pediatric, M probe, XL probe, which are actually adapted depending on the skin to capsule distance of the patient. So we could be tempted, because XL probe helps applicability of the FibroScan to scan everybody with XL. We also hear very often that if you compare M and XL probe on the same patient, there is lower values with XL probe compared to M probe. So what we should stress is, because each probe is dedicated to one type of patient, we shouldn't compare two probes on the same patient, because we are comparing different measurement depths, different ultrasound frequencies. What often happens is, if you scan an overweight patient with M probe, as it has been seen earlier, you get unreliable results because of fat subcutaneous tissue, so it would make the results higher with the M compared to the XL. So because of that, we stress on the importance to rely on the automatic recommendation tool that you have on the FibroScan. Of course, in some cases, you will have some doubts between M and XL, because maybe the patient is just borderline in terms of SCD. So in that case, if you have any doubt, you should prefer the XL probe, because you get rid of risk of overestimations. However, if you look at the recent data, and this is, I think, the next slide, when you take into account the influence of the probe on the liver stiffness values, and these are data published this year, we can see, this is a UK study, that no matter the stage of fibrosis, if you use the correct probe based on the official recommendation from EcoSense, you can see that there is no difference in the stiffness value. So we believe, EcoSense, that we could use actually the same scale of values for M and for XL probe, if, of course, the probe is used based on the skin to capsule distance. Louise and Patrick would like to comment.
No, I completely agree.
Yeah.
I think that, it is about the assessment of the patient, and when you want to take the scan, you're actually, it's quite clear what scan you should use. I mean, I don't really understand the question about should you use an XL probe on everybody. The short answer to that would be no, because the probes are designed for different skin to capsule distances. So I think it's important that we make a clinical judgment about what probe you might start with, and then you follow what the FibroScan machine is dictating you should do.
Yeah. Sometimes I'll use a different probe to target a particular spot, particularly if I've got a difficult to scan patient. Sometimes you just can't find the right spot. And the one advantage of the XL probe, if you get between the ribs, is actually you can soften you dent the skin, you put the pressure mark in the skin, you can actually localize a point that you can then use the medium probe for. So, and a lot of patients come on the cusp. And for some people, I alluded to it earlier, who smoke, with their lung volume, the liver can come in and out of focus. So sometimes it'll say XL, the next minute it'll be medium. So actually knowing and spending the time with the patient to find the right position for those patients is important. It is not just we've only got 5 minutes, let's scan you. Each patient has to be individual.
Thank you. So coming to the next question here we have, are my FibroScan stiffness readings influenced by respiratory motions?
Well, I think
Lewis,
we've just covered
that
through some of the sessions, but I think, yes, obviously they're also affected because we see a lot of patients now with pulmonary fibrosis, chronic obstructive airways disease, looking for any form of liver stiffness and portal hypertension as a factor that could be behind that. So those patients have more difficulty when you lie them flat. So again, you might just need to alter positions on the bed for the patient's comfort. But also knowing that if you go too high, you're going to bring the ribs down. So sometimes they can be quite complex and challenging scans. Patients should lie flat, as we've said, for at least 3 minutes prior to, and that gives you the time to talk to them, introduce them to it, put the data into the machine. So that should take you about the time to calm that patient down. And as you start the scan, you'll often start with higher readings, I don't know about you, and then you see them come down and down and down as the patient, and once they start to plateau off, that's when you're looking to start your 10 readings. So you're trying to exclude, and we can take them off the machine for the top ones. So again, quality controlling as you're scanning, not after you've completed the scan, gives you really good scans.
I think that's a key, not just stopping at the first 10 readings. I think you should keep going on to maybe do 15 or 20 more to see what is the consistency.
Yeah.
And I think in the end towards you might have good consistent 10 readings that you can just store.
Yeah.
Okay, so going to the next question here we have, is there a quality criteria based on IQR for CAP? Again, I think we've discussed that in some of the slides before, but maybe Mark can
maybe to
tell
highlight
us.
again the position of EcoSense on that, Neha, is that it's true that if you read a little bit the recent literature, there has been some quality criteria suggested for the CAP related to the IQR of the CAP. We all know first, of course, there are reliability criteria regarding IQR for liver stiffness, so it's not about the 30%. We still have to take care of that, to take a look at that at the end of the exam. For the CAP, actually, if you look at this, again, recent data published, evaluating actually the relevance of this IQR-based reliability criteria for CAP, you can see on this data, they have tested the thresholds of 40 decibel per meter as an IQR and 30 decibel per meter. And if you look at the data, the diagnostic performance of the CAP versus histology versus biopsy is not actually different if for patients for examination with IQR below 30 or higher than 30, and it's the same if you take the 40 decibel per meter IQR criteria. So our conclusion, our position for EcoSense is not to recommend anything for now as a quality criteria for CAP. What we really stress is, again, to take a close look at the ultrasound signal, at the green bar, at the LTT. It helps to ensure a consistent readings for CAP. We expect actually CAP to be a little bit more variable compared to liver stiffness. It's due to the steatosis repartition within the liver. But again, for now, it's a little bit too early to recommend any IQR limit, I would say, for CAP examinations.
Yeah, I think this table shows us that no matter what the IQR should be, the CAP could be reliable. But would you suggest that keeping the IQR as lower as possible is a good reading, maybe from your experience?
Personally, I'd say yes. I think what you tend to see, and I think the old FibroScans used to show it really quite nicely with the chart across just the data, is that the more consistent you are, the more consistent that chart is, which means you have a lower IQR. And that seems to compare very well with the FibroScan kilopascals itself. So the lower the kilopascals in the right measurement at the right time in the right place, the more consistent the IQR I find in CAP.
I mean, it's about consistency, isn't it? I mean, everybody wants to see consistency in these, but I guess the take-home message here is that there aren't the data available yet, and we need to await the studies which will give us some clear guidance, as we have for the IQR median of 30% for median liver stiffness. So I guess so.
And the only other thing I'd comment on with the CAP is it seems to be consistent fasting or non-fasting, unlike the kilopascals, that we do know you need to fast for more than 3 hours, preferably. I don't know what data is available, but certainly in the real world, I tend to see that the CAP doesn't matter whether I'm bringing them back fasted, because we do real time, and then we bring them back if the kilopascals are elevated in a non-fasting state. But their CAP stays very consistent.
Okay, so going up to the next one here, we have...
Oh, so this is another one of the questions which actually picks up nicely on some of the clinical cases that we showed, because we talked about, and we mentioned this, Louise, that the importance of the person undertaking the FibroScan understands the patient in front of them, the condition they have, the amount of activity, where they are in terms of their presentation. Because the question here relates to whether high ferritin levels, again an acute phase marker, so will be elevated in inflammatory conditions and raised ALT/AST. Would you repeat the FibroScan once the ferritin level has reduced? Short answer to that is most definitely we would. Would you repeat the FibroScan once the AST and ALT is reduced? Short answer is absolutely yes. And ideally, we want to see these patients when they're in a stable state without periods of inflammation or a lot of activity, which we know will give falsely elevated scores. So I think it's important that if you have a suspicion that you're seeing a patient during a flare of hepatitis or with significant biochemical activity, be that the ALT, the AST, you will want to see that patient again. And then similarly, ferritin as a marker of an acute phase response, yes. And as you're treating these patients or you see ferritin reduce, you will also want to see whether the FibroScan changes over the course of time. Important again.
Yeah. That's good. I think we have one more question here online. Asking, in patients with low kPa values, would you recommend doing the measurements in different spots? Would you...
With low kilopascal values?
Low kPa values, yeah.
I think, first of all, I'd look at the traces. Yeah. I think you can get, if you get ones and twos, they tend to be shearing off the rib to get an artificially low reading. Mm-hmm. However, if you've got great traces and everything passes, then, and it's a valid scan.
Right.
And therefore, I wouldn't necessarily... I have been clinically asked to rescan different areas of the liver because, of course, the liver is not necessarily uniform. Mm-hmm. And we've certainly picked up a mass in somebody who then went on to have a primary HCC in a non-cirrhotic liver. Yeah. And it was the FibroScan that was able to detect that. So knowing something, again, coming back to your point, knowing something about the referral reason for the patient and looking at that, detect things quite early, because I will then say, right, that's not normal. Let me see if there's something, if there's a normal tissue elsewhere. So I think two answers to that. If you've got great readings and you've got no reason to suspect that it's an invalid scan because it's shearing off the waves and your quality control is good, then you don't need to, particularly in low.
No, I think it comes down to the quality metrics. And as you said, Nia, that it's not just the first 10 readings. You're not going to do 10 readings and then you're finished. If you will look at the quality, you will look at the traces, you will look at the elastograms, and you're looking at those quality metrics. If the score is low, it's a low score if it fits those metrics. Yeah.
And Mark, I think, correct me if I'm wrong, that I think you cannot go wrong with the lower readings on the FibroScan. Usually it's the overestimations that could be wrong, and you might be doing wrong something there.
Yeah, I do confirm if usually when operator makes mistake, it almost always leads to overestimates of liver stiffness, I can see. So it's pretty...
So the lower values are always reassuring. So, all right, I think, So we have one more question here. So could you please comment on the value of repeating FibroScan within 3 to 6 months in patients with high readings?
Yeah,
again, could be a similar question.
Yeah, it's an interesting question. I think, well, it depends what you're doing the FibroScan for. So, I mean, very much picking up with some of the discussion we had earlier about an inflamed liver or a lot of biochemical activity, we know that that's not a good time to do a FibroScan. So if you FibroScan at a patient at time 0, when we know that that patient had significant biochemical activity with a lot of inflammation or pre-treatment or pre-intervention, there may be very good grounds to go back and rescan that patient at 3 or 6 months if the liver enzymes have normalized, and it would be an important test to undertake. But I would say more in routine clinical practice, that's not something that we would necessarily advocate. Right. A stable patient, for example, like the chronic hepatitis B patient that I scanned and showed you there, we wouldn't routinely repeat that FibroScan within 3 to 6 months. Stable patient, stable on treatment, there's no reason to think that this patient would have significant changes in their median liver stiffness or significant improvement. I think there's very, very specific reasons why you would do it in very short intervals. Louise, what do you think?
I think for newly diagnosed NAFLD, it's a behaviour change mechanism, and it's monitoring the behaviour change. When we do brief interventional advice with our FibroScans, the patient is most receptive at the time that you scan them. They are into the scan, they want to know the results, and people are inherently competitive. Because they have a CAP score, because they have a FibroScan score, they want to better it next year or next time. And I think if you're trying to change somebody's behaviour who's got early signs of quite high liver fat or is on the border of type 2 diabetes, they change their behaviour quite quickly. And one way to look at that is to look at the CAP score. Forget the kilopascals particularly, but the CAP, And again, will we research evidence this? I'm not too sure, because these aren't a group that you're going to biopsy just to watch a CAP score come down. But that motivational change, I can ask the patient, did you change something? Before I read the second result. And 9 times out of 10, they are really reassured that they have made a change that has brought their CAP down. I think there's a very good study done in Spain on alcohol detoxification using the CAP to watch the flare of the CAP comes down with the sugar content, with the fat content coming down. The kilopascal stabilises as the liver function stabilises, but the CAP continues to come down. So that motivational intervention for these people is massive. And I think I used case 2 there of this teenager. He went off and lost. Often teenagers do not change advice because they're too young and they're immortal at that age. But he went off and lost 8 kilos in just over 8 weeks. He normalised his CAP and he normalised his kilopascals, which is one version I see. But sometimes, and I don't know about you, as the CAP score comes down, sometimes the kilopascals can go up because I think the background tissue is stiffer and we're only measuring large fat.
Well, I mean, in terms of objectivity, if we know, we tell patients all the time that hepatic steatosis is reversible with lifestyle intervention, with the changes that you make. If you want to have a clear, demonstrate a change of lifestyle and a readout in terms of CAP, it's a very good tool to be able to do that. So there are certain reasons, and this is why looking or considering the patient that you're going to scan makes a lot of sense, and that's why you will look at every patient differently.
And I think going back, for somebody who hasn't made changes, there's nothing like saying, "Ooh, you didn't make any changes, did you? Because I can see that." It's like, "Ooh." There is a reaction. And I think it takes away the, "Yes, doctor, I changed my behaviour from the last time you saw me. I've drunk less, but I look the same and you can't tell." It removes that from the excuses and the armoury. And I think that is a very powerful motivator for patients when we see them in real time at their scan.
Right, thank you so much. I think we've come to the end of the webinar today. I would like to thank you all for your time that you've taken and logged in for this webinar. And I'm really grateful for Patrick and Lewis and Mark to be helping us with the insightful discussion here. For the users who've not been able to log in today, we will record this webinar and we will put it on our EcoSense TV channel on YouTube. So please feel free to go and have a look whenever you get a chance. And we will also have some other topics of the webinar on the channel as well. So thank you for now. Good day, and see you next time. Thank you.